keep their microphone muted. It might also be a good idea to keep your camera turned off just to prevent distractions so that everyone can keep their eyes on the presentation and not be admiring the backgrounds of your homes. And at this time, Dr. Early, I'm going to turn it over to you and say welcome.
Well, thank you very much. It's always a pleasure to be with this group. And I can't tell you how much I appreciate the support you give to the newly diagnosed women who feel alone and afraid, and being able to have a community to rely on is so important. I wish we could meet in person, but the topic I was asked to talk about today is what can I do to reduce my risk of breast cancer recurrence? So I gave a lot of thought to this, and I'm going to go through a number of topics, but we'll leave time for questions and comments at the end. I ranked them for the most part in order of what I think to be most important to generally important. So extended hormonal therapy for women with hormone receptor positive breast cancer. Adjuvant bisphosphonates, that is Zometa, in postmenopausal women with breast cancer. We'll talk about healthy lifestyle, avoidance of estrogen replacement. It's not strictly on topic, but there is a new guideline on imaging for breast implants. And many of you had so many questions about the reports over the last 2 years of these unusual lymphomas in women that have breast implants. So I do want to spend some time talking about that. And then we can't ignore the issues of general health. Woman with breast cancer becomes so focused on her cancer diagnosis, always forgets that she's likely to be a survivor for many years and needs to take care of her health overall. So I think this topic is important. And then we'll do questions and comments. So the first of all, adjuvant endocrine therapy, an update from the American Society of Clinical Oncology. Panel recommends that women with lymph node positive breast cancer receive extended hormonal therapy, including an aromatase inhibitor, that's anastrozole, letrozole, exemestane, for up to about 10 years. Many women with node negative breast cancer should also consider extended therapy for 10 years based on individual considerations of recurrence using prognostic factors. There is a calculator that was developed at the University of London. And you can ask your oncologist to plug your numbers in to this calculator when making a decision about continuing your hormone therapy. So many women find seeing these results objectively for her individual circumstances is helpful. The benefits for absolute risk reduction were modest, and for lower risk node negative or limited node positive cancer, an individualized approach for treatment consideration is necessary. So it's a risk benefit side effect versus risk reduction of the cancer. But I want to underscore that a great amount of the benefit for extended hormonal therapy is in prevention of second primary breast cancers. That is not a recurrence, but a cancer elsewhere in the same breast if there was a lumpectomy, or cancer in the opposite breast. I was struck to learn many years ago that a menopausal woman has a breast that has 80% of the estrogen of a premenopause woman. Now we know that a woman after menopause has low estrogen levels in the blood, but estrogen levels are quite high in the postmenopause breast. And the reason for that is there's a high amount of an enzyme called aromatase in the breast. So aromatase inhibitors like anastrozole, letrozole, lexamestane block this aromatase enzyme. And that's why one sees substantial benefit in reduction of second breast cancers, not recurrences. This is just a summary of the extended adjuvant trials that were published. And what one can see, basically looking at HR, hazard ratio for disease-free survival. In other words, being alive, being well, and without cancers. And in all of these trials, you can see a meaningful benefit from continuing the hormonal therapy. Now, the second consideration is adjuvant. Adjuvant means treatment to reduce risk. Bisphosphonates, and bisphosphonates are Zometa and other bone modifying agents like Exgiva. And this is a guideline from Cancer Care Ontario and the American Society of Clinical Oncology, and it's the practice guideline for both groups. It is recommended that if available, zoledronic acid, that is Zometa, be given intravenously every 6 months, or clodronate, which is not available in the United States, be considered as adjuvant therapy for postmenopause women, and that can include young women who have been made postmenopause by chemotherapy or by ovary suppression or ovary removal, who are deemed candidates for systemic therapy. Further research comparing the different bone modifying agents, doses, intervals, and duration are needed. Right now, our data is with Zometa. We really don't have the data presently for Exgiva, but it's certainly appropriate to use Exgiva in the appropriate woman. So Exgiva we would use for a woman that's got weak kidneys, primarily. So you can see in the bottom line here, data for adjuvant denosumab, which is Exgiva, look promising, but are currently insufficient to make any recommendations. Now, what are the risks? Well, the risk of the Zometa is a dental problem, something called osteonecrosis of the jaw. Fortunately, it's very uncommon, about 1% or so. But it's a significant problem if it happens. And this occurs in a setting where a woman has to have a tooth extracted or a root canal and the tooth socket doesn't heal, and can result in a very difficult to heal ulcer of the jaw. So given that, we recommend that a woman have a dental evaluation. If a woman's had a recent, within the last year dental examination and have no problems, that's sufficient. But otherwise, it's best for a woman to see a dentist before beginning this treatment. And with Zometa, but not Exgiva, drugs can be a bit hard on the kidneys, so we monitor the kidney function. The other two problems that can happen is some women will have some generalized bone pain for day 2 or 3 after getting the Zometa infusion. It's generally limited in duration, but it's good for the woman to know, so she's not concerned if this should happen. Now, big topic, weight loss, and this has been talked about in medical meetings for years. The leader is Dr. Chelabowski at the University of Pittsburgh, and he was the first person that led the charge on this and was involved with the original publications. So what we know is that an excess body weight, or BMI, body mass index, is a negative influence on prognosis in breast cancer patients, both premenopause women and postmenopause women. So you should all know your BMI, and you can Google a calculator and find the National Institutes of Health calculator. You plug in your height and your weight, and you can get your BMR. So the hazard ratio, in other words, the significance on recurrence, was significant in a meta-analysis. It certainly wasn't doubled, but it was a significant factor. The potential mediating factor or causing factors are change in hormones. So what we know is fatty tissue, adipose tissue, takes some of the cortisone, that's a normal hormone produced by our adrenal glands, but it changes the cortisone into estrogen. So that's why women who are post-menopause or who don't have ovaries or whose ovaries are suppressed still have estrogen levels because it's coming from cortisone. So women with excess body fat, and that's primarily the central fat, the apple shape as opposed to the pear shape, will have higher levels of estrogen in the blood. So postmenopausal women with a BMI of over 30, so that would be considered the cutoff for obesity, have higher concentration of blood estrogen. There's some other factors in play where obesity increases circulating insulin and insulin-like growth factors that have some role in breast cancer recurrence, though to the present time rather poorly defined. Situation is different for weight loss in premenopause women. Obesity is not associated in young women with an increased risk of breast cancer, but represents a risk for recurrence. Now, weight loss. So we know that low-fat diets lower estrogen in the blood. And women that exercise regularly have a 15 to 25% lower circulating estrogens, and also the male hormone androgen. Nutrition and physical activity on outcome. So the best diet for all of us, both in terms of breast health and in terms of heart health, is the Mediterranean diet. And you all know the Mediterranean diet. It's lots of vegetables and fruit, a lot of fish, a lot of beans, very, very little red meat. But candidly, associations are modest. Now, most women ask about vitamins and other supplements, but the findings are really mixed. And we'll talk about this in a slide or two. The benefit of physical activity has shown benefit in meta-analysis, and a meta-analysis is when a writer pools all the available studies in the literature and analyzes all the results pooled. So the American Cancer Society and the American Society of Clinical Oncology Survivorship Care Guidelines, last done in 2015. Now, I've not included all of them, but they're all available. You can Google this guideline to read the whole guideline. But bone health, a DEXA scan, that is an osteoporosis scan every 2 years. Counseling to achieve and maintain healthy weight, limit the consumption of high-calorie foods and beverages. And I will be embarrassed and show you my ginger ale. I've gone to eating mostly clean, except I cannot give up my ginger ale. Increase physical activity. And for physical activity, our goal is 150 minutes of moderate exercise or 75 minutes of aerobic exercise weekly. Strength training, that is free weights or resistance machines, at least twice a week. And general nutrition counseling for women who are at healthy weight, underweight, overweight. Achieve a diet high in vegetables, fruit with grains and beans, low saturated fat. Limited alcohol consumption, but there's no recommendation to avoid alcohol. The risk of moderate alcohol consumption is none to limited, but I would stress limited. And for a woman, that's 1 alcoholic drink a day. Vitamins and supplement. Most women in America do not need vitamins or supplements except for vitamin D. And I think we all need to take vitamin D, especially in the winter. Vitamin D is metabolized in the skin through exposure to sunshine. So less of an issue if you winter in Florida or Arizona. But most of us who live in Western New York, when we don't have much winter sunshine, and when we do, we're covered up with a hat and clothing, have a low vitamin D level. So if it's not been done, ask your primary care or ask your oncologist to check your vitamin D level. If it's normal, my recommendation is 2,000 units a day. But if your vitamin D level is low, then there's a need for prescription strength vitamin D replacement till you get your vitamin D levels up to normal. Number of years ago, I was having just generalized bone achiness, and I thought, well, it's getting older. But I had my vitamin D checked and it was in the toilet. So I started replacement vitamin D and found that my joint symptoms almost completely went away. So most of us need to be taking some vitamin D. Now, my take, walking and free weights at home or in the gym for exercise goals. For aerobic exercise, you really don't need to do much more than walk. Certainly you can use a bicycle, a stationary cycle, a treadmill. You can run if you run, but really what we need is walking. And you can use some free weights at home or do the resistance machines at the gym. Mediterranean diet is best, but realistically, an 80-20 eating pattern may be the most realistic and easier to maintain, which means that most days you're eating a very healthy Mediterranean diet, but on the weekends, you can cheat. If we tell ourselves we're never going to have a piece of cake or a steak again, we're going to want it even more. So in the optimal situation, a Mediterranean diet 100%, but for something that one can stick to and is realistic, plan your cheat days. I believe nurturing the spirit is just as important as being a diet zealous. So it's okay to have a glass of cake or a slice of cake and a glass of sparkling wine on your friend's birthday. Moderate alcohol is 1 drink a day for women. It's best to avoid phytoestrogens. Now, phytoestrogens are plant estrogens. So that includes soy supplements, something like black cohosh that some women will take for hot flashes. But risk is likely negligible. There was a Japanese study that really didn't show a risk. So again, I don't think you need to be a zealot. I wouldn't seek out soy supplements. I wouldn't buy soy milk. I think it's okay to have an occasional tofu dish at your favorite Chinese restaurant. And if you don't want dairy milk, there are now some really nice options like almond milk. So another hot topic, the increased risk of recurrence after hormone replacement therapy in breast cancer survivors. And this was a big study called the HABIT study, reported in the Journal of the National Cancer Institute in 2008. We have to acknowledge that hormone replacement therapy, that is estrogen, increases the risk of breast cancer in healthy women. The randomized HABIT study was among women who had, among breast cancer survivors, women who had previously been treated for breast cancer. This study was stopped early because the evidence for increased risk of new breast cancers following hormone replacement therapy was striking. The incidences of new breast cancer event at 5 years, 22.2% in the group receiving hormone replacement and 8% in the control group. Hence, it was concluded that clinically and statistically increased risk of new breast cancer events occurred in survivors who took hormone replacement therapy. Well, why do we want to take hormone replacement therapy? We talked a little bit about bone health, and we know that estrogens keep our bones strong, but we have an option. We have the option of exercise and weight-bearing exercise, Zometa and Xgeva. So we have vitamin D. So we have options for non-hormone treatment for bone health. I'm going to talk in some detail about the vaginal symptoms because that's a very significant issue for many women. So I just have a recent publication looking at the risk, and I put this on just to show you here the graph, which the light line is recurrences in the group not taking hormone replacement, and the dark line is recurrences in women taking hormone replacement. And you can see that the risk increases over time. So what can I do for vaginal dryness? A significant problem for women on the aromatase inhibitors. So the symptoms are vaginal dryness, vaginal itching, painful intercourse, which women are often reluctant to talk about, but we urge you to talk about it. Frequent urinary infections, vaginal soreness, and spotting. So the aromatase inhibitors, the anastrozole, the letrozole, the exemestane, are potent inhibitors of estrogen. Symptoms are less with fulvestrant. Fulvestrant is used as a second-line hormone therapy or third-line in metastatic breast cancer. So symptoms of urogenital, that is the urethra, the tube from the bladder, and genital, the vaginal, atrophy, which can mean weakening of the tissues, can usually be relieved with vaginal estrogen preparations. But the risk of recurrence and the safety has not been well defined in women with a history of breast cancer. Treatment with non-hormones, including vaginal moisturizers or lubricants and lifestyle modifications, are the first line of management. Now, the non-hormonal modalities are vaginal moisturizers. You can use KY jelly, but KY jelly is water-based. So it's only going to be helpful for a very short time. It's better to use a vaginal moisturizer. These are over the counter. Replens is one that is common. There is a vaginal moisturizer that I'm always hesitant to even mention because I think it was named by an overly confident man. It's called Astroglide, and you can buy it off the shelf at Wegmans. A lot of women have had good results with coconut butter. Although in preparation for this talk, I did some review of that, and gynecologists are a little bit concerned that there may be an increased risk of vaginal infections with coconut butter, coconut oil. So probably best off using Replens as a vaginal moisturizer. Now I'm going to show you information from a study that I participated in with a woman's health doctor at Mayo Clinic and a gynecologic endocrinologist at George Washington University. And we looked at vaginal estrogen preparations and how much estrogen is actually absorbed. What we found that there is negligible absorption with low-dose vaginal estradiol tablets, tablets that you insert into the vagina, or with something called the E-string. It's E and then string. It is, it's a device that looks like a diaphragm without the cap. It's a silicone ring impregnated with estrogen. It's put in like a diaphragm and left in place for 3 months and then changed. So these two options give negligible estrogen in the blood and can be considered treatment for women that are symptomatic with the vaginal dryness and symptoms after discussion with a woman. While effective in treating these symptoms, we don't have long-term information, but I've been very comfortable allowing the low-dose vaginal estrogen tablets or the East string, because the symptoms and the impact on quality of life can be quite substantial with the vaginal dryness. So current overview of urogenital atrophy in women with breast cancer. Dr. Pruthi is a women's health specialist at Mayo. Dr. Simons is a gynecologic endocrinologist, and I participated as a breast oncologist. So what we looked at is we looked at different vaginal estrogen preparations and the maximum amount of dose that was given over a year. So Vagifem 10 micrograms tablets intravaginally, and that is inserted into the vagina once a day for 14 days, and then twice a week, gives serum levels that are minuscule, 4.6 picograms, and a maximum annual dose that is just fractionally over 1 milligram. The East string vaginal ring inserted every 3 months gives typical serum estrogen levels of 8 picograms per milliliter and a maximal annual dose of 2.74 milligrams. So tiny kind of levels. These preparations give considerably lower levels than other forms of estrogen. In our opinion, can be used if non-hormonal treatment is ineffective. Non-hormonal treatments are the moisturizers like Cleanse that are better than water-based like KY. Vitamin E stimulates sensory nerves and has improved sexual function. Now, what our gynecologists at Roswell have recently started using is lidocaine ointment, 5%. Lidocaine is the numbing agent that the dentist uses, or the agent that's given either on the skin or by injection as a numbing agent. But this can be inserted vaginally, as can gabapentin cream. Gabapentin is a medication that's used for painful neuropathy and chronic pain syndromes. So these two preparations can be used for painful intercourse. So I have to say, I asked the gynecologist, well, lidocaine may eliminate the painful intercourse, but does it block sexual response? You know, is a woman unable to achieve orgasm if she's numbed up her vaginal tissues with the lidocaine ointment? And the answer was no, it doesn't. Because the pain really initiates in the vaginal canal and not in the clitoris, which is the organ that results in sexual response. So, you know, you put the lidocaine ointment in the vaginal canal and you avoid the clitoris. So it doesn't impact sexual response. Okay, now a hot topic of late. And first of all, I don't want to frighten or concern anybody, because these implant-associated lymphomas are most uncommon. So breast implant-associated anaplastic large cell lymphoma, anaplastic means it's a bad lymphoma, is a non-Hodgkin's lymphoma, usually found in scar tissue fluid near the implant, but can sometimes spread throughout the body. An individual's risk is low. Treatment is usually with surgery to remove the implant and surrounding tissue, but some patients are going to need to have chemotherapy and radiation. So Symptoms are persistent swelling and or mass and or pain in the area of the implant. And these symptoms can occur many years after the implant has been placed. The risk is highest for textured surface implants versus smooth implants. There's very little reports of these lymphomas with smooth implants, but the reports that the FDA received were primarily in these textured implants, that sometimes called the ridged implants. And these are sometimes used for tissue expanders. So we don't recommend that these textured tissue expanders be used. Food and Drug Administration issued a recall of textured implants, and this is important because women ask, did not recommend routine removal in patients without symptoms. Again, because the risk is a very small risk. These are the recalled products. And a list for you that I think you folks are going to have this PowerPoint, so you can review. What you need to do is you need to find out what implant you have. Now plastic surgeons are giving women a card with the name, the serial number, all the information about the implant. But in past years, this wasn't done. So women don't know if they have a textured implant. They don't know what the make of the implant is. So that's, if you have a breast implant, that is something that you want to find out. Now, if your plastic surgeon has retired, it can be found on the surgical report. The surgeons will indicate the device. That may not include the serial number, but it'll include the device and whether it's a smooth or whether it's a textured implant. So the vast majority of these lymphomas have occurred in textured implant, according to information from the FDA. Now, this is self-reporting to the FDA, nothing that was prospective. So it's said that the risk is about 1 in 1,000 to 1 in 30,000 women with textured implants. I know that's not very helpful, but that's the best we can do with information that's not prospective, in other words, not evaluated ahead of time. The exact cause of this lymphoma is not known, but risks seem to increase with the textured surfaces. It does not seem to matter if the implant is filled with silicone or saline. So that's important for you to know. Textured implants may cause more inflammation than smooth implants. So possible causing factors include reaction to implant particles, allergies, genetic factors, reaction to bacteria more likely to grow in the textured implant surface. And there doesn't seem to be difference in the risk among women who had their implants for cosmetic breast augmentation or breast reconstructive surgery. Now, this is a guideline update that the Food and Drug Administration just released this past September. So supplement to the FDA's guidance on saline, silicone gel, and alternative breast implants issued September 2020. The FDA believes there should be a box warning that is included in labeling for both the physician and the patient breast implants are not considered lifetime devices. The risk of complications increase over time, and some complications like leaking, deflation, or these lymphomas require more surgery. Breast implants have been associated with the development of a cancer of the immune system called breast implant-associated anaplastic large cell lymphoma. And breast implants have been associated with systemic symptoms, fatigue, joint symptoms primarily. So what is new, and what most of you have not heard yet, is there are, as of September, some implant screening recommendations that we didn't have before. So even though this is not a risk of recurrence issue, I just felt it's important enough to include in this talk. So in a woman with no symptoms, she should have a breast ultrasound or an MRI at about 5 years after her implant surgery, then every 2 to 3 years. So again, bring this up with your cancer care team or plastic surgeons. This is new recommendation. And now you ladies can't forget about your general health. And so often I see this happen, but please take care of your health. You need to see your primary care practitioner and your gynecologist once a year. Mutation carriers like the women with BRCA mutation should be seen by a gynecologist every 6 months if her uterus and ovaries are intact. Hereditary cancer mutations should be evaluated more frequently than once a year. Screening for secondary, and I said secondary cancers, but that's, I typed that wrong. Screening for the average risk woman should include cholesterol, lipids, cancer screenings like colonoscopies, and pap smears, and the DEXA osteoporosis scan. Now, smoking cessation, we need to mention. For those who are former smokers or current smokers, there is screening that is very successful for lung cancer. The United States Preventative Services Task Force recommends yearly lung cancer screening with low-dose CAT scan for people who have a 20-pack year or more smoking history and who smoke now or have quit within the past 15 years and are between 50 and 80 years of age. So a pack year is an average of 1 pack a day for 1 year. So for example, a person could have a 20-pack year history by smoking 1 pack a day for 20 years or 2 pack a day for 10 years. And then I don't have to tell you in this COVID pandemic how important it is to be current with your immunizations. So we covered a lot, and what I'd like to do at this point is to open our hour up for questions and comments.
Thank you so much, Dr. Early, for your presentation, for all the valuable information. Ladies, you're welcome to turn your video cameras back on. There is a chat function at the bottom of your screen if you're on a computer or a laptop. So you can click in the chat box and type your question, or if you know how to raise the emoji hand, it's under participants. You can click on participants to raise the hand. Dr. Early, can you turn the screen sharing off, and that way we will all be able to see each other?
Absolutely. Okay, hi everybody.
Excellent. So there's a few cameras on. Please, everyone, you're welcome to turn cameras on because we don't get to see that many people in person these days, do we? So, Dr. Early, there was a question in the chat regarding diet. So Elizabeth Giles wrote, I eat a very good vegetable-based diet on the whole, but my weakness is sweets. Let's all raise our hands if we can relate to that. And she says, without which I feel cravings no matter how much food I've eaten. Is there any advice for how to get over a sugar addiction?
Oh, that is hard. Our insulin levels spike after we have had a high sugar food intake, and that stimulates hormones that make us want more sugar. So limiting sugar to begin with is one way. But the other way is if you're sensitive to sugar, eating several things. Eating frequent small meals as opposed to 3 big meals is helpful because it'll keep your insulin level more steady during the day. So that can be helpful. And the other thing is nutritionists say, always combine your carbs, especially your sugary carbs, with a protein. Now, you might take that to mean a Reese's peanut butter cup is good because it has sugar and it has protein. But, realistically, if always match your carbohydrate, especially your sugary carbohydrate, with some protein, it'll slow absorption of the sugar. And that'll be important. You'll be less likely to be craving sugar. So, what I buy for my grandkids are those Nutella sticks. Nutella is a combination of sugar and protein. It's nut butter with some chocolate. So you can go to Wegmans and you can buy these little containers of breadsticks with Nutella. So add some protein to your carbohydrates. So more frequent meals.
It sounds like something I could try, but I have to admit that over the years, kind of listening to my body and what's going on, it's almost like I'll keep eating the sugar until I get the ding. So it's not even like I put a little sweetness on my tongue and like, oh, that satisfies me. I know that what I'm looking for is that they say it's like a heroin hit or something. You kind of get that.
No, you're right.
Yeah.
And, ideally, we should avoid artificial sweeteners. I will admit that I occasionally use stevia, which is a natural sweetener. Honey is probably less of a problem. But it can be difficult. Many of us have taste buds that are attuned to sweet. Others, the salty. I tend to be more of a salty person myself, so I don't dare do even that one potato chip. But we are all different in that way. Our taste buds are different. I have decided for myself it's safe to use in great moderation stevia to get my sugar fix. Some of the natural sugars like monk fruit can be helpful. But again, I don't think you need to completely avoid it, because if you do that, you're going to be thinking about it so often, you're going to sit and eat half a bag of Reese's Pieces.
Yeah, I've heard that, but I've also heard that people who can manage to give it up cold turkey for either 2 or 3 weeks get over the craving. And I've never been able to get that far without chewing the pillowcases at night. So I don't mean to make light of any of this. I mean, it's funny because our culture just is like revolves around sugar. Think of a holiday, Easter, Halloween, blah, blah, all the Christmas, right? All of these, everything we do seems to be revolving around sugar. It's hard to avoid, but it's probably a lot more harmful. If anybody's a Robert Lustig fan, they would know what I'm on about. He was just on the People's Pharmacy this weekend, talking about how, we don't take it seriously enough. How sugar is, related to all the things that we used to blame fat for: heart disease, cancer, diabetes, a number of different chronic diseases. So knowing, and I have metastatic breast cancer, so I know it's important to try, and it can't hurt me to give up sugar, but it's just been a really difficult path, more difficult than exercising and the other advice that you gave us. So
thank you, Elizabeth, for your question, and Dr. Early for your response. I want to go on to a few other questions that we have. So a follow-up to the diet question, and then Marge, I'll go back to your question. But Debbie asked, is lean dairy okay in a Mediterranean diet? Since we're on the topic of diet right now. Is lean dairy okay?
And I'm sorry, but just repeat it once more for me.
Sure. Is lean dairy okay in a Mediterranean diet?
I think it is. I think it is. Certainly, it's good to get it's a good source of calcium and vitamin D. Yogurt, especially prebiotic yogurt, Greek yogurt, is an extremely healthful food and can be incorporated as part of a Mediterranean diet. Some women prefer non-dairy milk, of which we have choices, but I recommend avoiding soy milk and using rice milk or almond milk instead.
Thank you. Another question we have from Marge. If you have been diagnosed with a second breast cancer, is the risk of recurrence from your first breast cancer higher?
It is not. It is not. So I tell women that get a second breast cancer, the other breast, someplace else in the same risk, that we're starting out day one again. So your risk is not higher. Now, certainly that woman should have genetic testing, because that's a red flag for hereditary breast cancer.
Thank you. A question from Sherry. She asks, are there any new developments for triple negative breast cancer?
Yeah, very much so. And this is a whole exploding area of immune therapy for triple negative breast cancer. One of my partners, Dr. Shipra Gandhi, Ghandi, has pioneered our immune therapy clinical trials in breast cancer at Roswell. And I guess I would put out there that I think it would be really helpful to invite Dr. Gandhi to give a discussion on that topic. We're also in the new area of looking at genomics, genetic testing, aside from the PD-L1 in triple breast cancer. So within the last 2 years, some extraordinarily substantial headway being made.
Thank you. Another question is about Zometa. So Christine wrote, I've been on Zometa for 3 years, and it has been suggested that I continue for another 2 years. What is the general recommendation for how long to be on Zometa?
Well, your doctor's right on track. That is the current guideline of the American Osteoporosis Foundation and most medical oncologists, but the American Osteoporosis Foundation came out with a strong and a very good guideline. The reason is that there have been some reports of what we call atypical fractures when being on the Zometa for a long time. Now, that doesn't mean that you can't come off, and in a few years, if you start losing bone, go back on. But yes, your doctor's right on track with the recent guidelines.
Thank you, Dr. Early. Another question from Angela. Is the current recommendation to continue anastrozole for 10 years instead of 5? If yes, are there increased side effects?
Well, the answer is for most women, yes, it's better to stay on for 10 years. Now, a very low risk woman, negative nodes, she could safely discontinue at 5 years. The increased risk has to do with the bones, so that the longer you're on the aromatase inhibitor, the longer the risk for bone loss. But I think that can be circumvented by watching the bone density carefully, by giving one of the osteoporosis drugs if needed, by watching the vitamin D, taking some supplemental vitamin D. So the only real long-term side effect is the potential for bone loss.
Okay, thank you. Aside from the nutrition and the exercise, are there any follow-up care treatments for preventing a recurrence of triple negative breast cancer?
Well, you know, the things, not anything more than the things we've talked about. Except I would say that that's not my dog. My dog's being good. But the things we talked about, but also for triple negative, I think many of you know that triple negative is also a red flag for hereditary breast cancer in the BRCA mutation. So triple negative breast cancer woman should have genetic testing, because if there's a gene mutation, there are additional preventative things that should be done. You know, when the BRCA mutation carriers, for instance, you have to think about pancreatic cancer, ovarian cancer. So that would be the important thing for triple negative.
Thank you, Dr. Early. Another question is, are there specific types of breast cancer that are more common to reoccur?
More common
for a recurrence?
Well, good question, and a difficult question. Triple negative breast cancers and HER2 breast cancers, they're going to recur, they occur early on. So a woman with HER2 positive breast cancer has gotten rid of most of her risk by 4 years. It's the estrogen positive breast cancers that can result in a late recurrence. So in the past, before we used these extended hormonal therapies, 50% of recurrences in hormone receptor positive breast cancer were after 5 years. So in terms of overall risk, the risk of recurrence is higher. With triple negative breast cancer, very certainly, these are usually high-grade tumors and just overall have a higher risk of recurrence. But estrogen positive, lower grade breast cancers can carry the risk of late recurrences. So these recurrences that we can see after 5 years.
Thank you. Beth asked if you could repeat what you said about the benefits of denosumab versus the zoledronic acid.
They're probably equal. It's just that we don't have an FDA official blessing approval for adjuvant treatment in women on aromatase inhibitors for Xgeva yet. Xgeva is more costly, but we do use it for a woman that has weak kidneys. It's a little easier instead of having, it's a 15-minute IV, but instead of coming in for the IV, the denosumab or the Xgeva is a shot in the arm. We all think that the clinical trials will show that the benefit is equal.
Thank you for that. And Deborah, I apologize. Deborah wanted us to know it was her question about the triple negative breast cancer. So I apologize for that, Deborah. Jory or Marjorie asked, is there any connection between taking anastrozole and high blood sugar?
To my knowledge, there is not. Some women on their breast cancer drugs will gain some weight, so that's going to have an association with high blood sugar. But it is not considered a risk factor, and I'm not aware of any association with high blood sugars.
Thank you.
I've always found that men and women with all kinds of cancer, they tend to crave carbohydrates. And I'm not sure why that is, but it seems so common.
Thank you, Dr. Early. There's no other questions in the chat right now. And we do try to keep our presentations around an hour. So it's 7:31 right now. Ladies, does anyone have a last question for the good of the order while we have Dr. Early online? Feel free to unmute yourself if you do have a last question. All right. Go ahead, Elizabeth.
Trying to articulate it. I have metastatic breast cancer, so a lot of times when I'm hearing about risks of recurrence, I mean, it's not like my cancer has ever gone away. It's just at bay right now. So I don't know, Dr. Early, do you have any comments about development hope, let's say, for people with metastatic breast cancer? I mean, I've been told by very honest doctors, and God bless them for being so honest, that I am terminal, but it's always a question of, how many years do I have left? So I'm just wondering if there have been any cures or any cures on the horizon, any comments that you have about metastatic breast cancer.
Well, absolutely, yes. May I ask, are you estrogen receptor positive?
I believe so. I always lose track of it because I try not to think about my cancer on a daily basis. I should know that.
So, you see these commercials on television every night for Ibrance. This is and there are other brands, but this is the non-chemotherapy drug given along with a hormone treatment, typically anastrozole or letrozole to increase the response. And I have to tell you, these commercials on television are not really exaggerating. Women that with metastatic disease who are taking drugs like Ibrance, the generic is palbociclib, with their hormone therapy, whether it's anastrozole, letrozole, Faslodex, are doing so well for so long. I have a very dear friend, and she was one of the first people I started on Ibrance, and she has been fine for years. So that's made a huge drug in the estrogen positive breast cancer women. And then again, please get Dr. Gandhi by, because the immune therapies in triple negative breast cancer have resulted in some very striking responses. We have no new drugs for HER2 positive that have really extended survival, like using double antibodies, using the Herceptin that most of us know about, but combining it with Perjeta, a second HER2 drug. So the advances have been all across the spectrum, hormone positive, HER2 positive, triple negative.
Yeah, I am on Ibrance and anastrozole. I just wonder, what I know you can't really say, but what the prognosis is. Like when you say for years, does years mean 2 years, 5 years, 10?
These drugs haven't been available all that long, but there's certainly women doing fine beyond 5 years. And, we hope that we're going to see those women doing fine beyond 10 years. We haven't had the drugs that long. So that remains to be seen. But women that we wouldn't have expected to do well for a long time are doing well for a long time.
Thank you, Dr. Early. And Elizabeth, I just want you to know that there's several women on this call that have metastatic breast cancer, including myself. And everyone's terminal from the day that they're born. So what's important is that we live now, okay? You're welcome to join our Living with Metastatic Breast Cancer support group, which meets on Tuesdays. And there's information about that on the BCN website. Okay, so at this time, I just want to thank Dr. Early for giving of her time this evening. And I also want to thank all of you lovely, beautiful ladies that are online with us tonight. Looks like there's 36 of us on the call. This Zoom webinar is being recorded, and I will talk to Rob about having it sent out, or at least getting the PowerPoint sent out, because I don't want to violate people's privacy by having the recording sent out with our names and our faces. So I'll try and get the PowerPoint slides sent out to each of you. And with that, I just want to wish you a wonderful evening and thank you for joining us tonight.
I wish the best to all of you. I wish we could meet in person, but it'll be within a few months.
Thank
Bye,
you.
everybody.
And thank you again, Dr. Early. Good night, everybody.
Most welcome. Bye.
Bye-bye. Thank you.
Bye. Thank you so much. Thank you.